And
Yes, I am able to hear you.
and remember, if you have response tabs, you can put your thumbs up or agree. So let's everybody mute so we don't get a lot of background feed noise. Okay. So this is the interventions, medication, and administration lecture. It does come in two parts. You're going to get half of the lecture today and half of the lecture next week when we come back from our break. I do want to say, I know I have a lot of skills and reading material in the text. You are responsible for all the material in the text. So it's important that you read that. Are you guys hearing the ding, ding, ding as everybody comes in?
Yes, the ding 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 is people
Yeah.
coming.
Yeah.
Okay. Well, we're up to 105. How many are in this group, Mystique?
More than 150.
I don't know how many.
Okay.
You have the capability of turning that chime off. And when I lectured, I did it. But I am trying to do it for you, and I don't see the capability of me to do it.
How can I do that?
I just did it. I just did it.
Thank you, Miss Matana.
Thank you. Yes. Okay.
You're hired.
So one of the most important things to remember about medication administration is you are individually responsible for each action that you not overtake, but each action drug that you administer, you are the final responsibility for any activities and medication. That's why you get a nursing license and you are responsible to the State Board of Nursing, whatever state you're practicing in. Here it's the Louisiana State Board of Nursing, and they establish your scope of practice, and you are responsible for knowing any updates or any changes that affect your care that you're providing. All of the doses of medications, they have to be verified for the safe range for each specific patient. And you have to know for each med that you give, what am I doing? Is it the right med? So that's why it's so important that we pay attention to the details. I do want to say, if you look at this is all of the different organizations or governing bodies that impact the care that you give in medication administration. Some of them, if you look, they have an asterisk by them: the CMS, the ADA, the WHO, the CDC, OSHA, NCLEX, these are, and the FDA. These are all government regulatory bodies. They set the guidelines. It is the law. When you practice medication administration, all of these have an impact on the care that you give. And the others, such as the Joint Commission, it doesn't have an asterisk by it. It's an accrediting body. That means the healthcare organization that you're working in is either a member of the Joint Commission. What happens is third-party insurers like the Center for Medicare and Medicaid Services, which is a federal government body, they say if you meet the Joint Commission guidelines, then you meet our guidelines. Someone raised their hand. Sarah raised her hand.
Yes, a lot of us are hearing like this new noise of feedback, like a ringing almost in the background.
That means somebody didn't mute their speaker.
Muted.
Microphone.
Let me go down. Mr. Keller, it looks like you're not muted. I'm going down the participant list. Please mute your microphone. Hold on, let me try one thing here. I do hear my freezer running. Hold on. Is that better?
Yes, ma'am.
Yes.
Yes.
My little refrigerator. Okay, so let's proceed on. Thank you for letting me know. I appreciate that. So what's important to remember is you'll hear people talk about the Joint Commission and we have to follow Joint Commission. That's because the federal government who writes the law says that you do have to follow Joint Commission guidelines. You'll see here the Institute for Safe Medicine Practice. And look at these tables, table 35-9, page 773. These are guidelines for protecting you and your patient while you're practicing medication administration. Over here, you have OSHA. That's the Occupational Safety and Health. Your facility has to provide you the PPE, including filter needles or hoods, whatever's necessary for you to provide safe medication administration. So if you look at these, all of these, and you'll see as we go through the FDA, everybody knows narcotics are under control. Those are on table 35-2. It's your responsibility to know what are the guidelines for the facility where I'm working, the accrediting bodies, and the federal guidelines or the government regulatory agencies. So QSEM, that's the Quality for Safety and Education. This is saying that by the time you finish your program here, you will be able to meet the QSEM guidelines. So one of the things you see here, examine human factors and other basic safety design principles. What do we see here? You're going to see this over and over again. You're going to see technology integrated. There are facilities that they keep track of how often you barcode, or sometimes if you override the reading of the barcode, they want to know, because it's proven through research that when you follow your safe practices, and that you have less incidence of medication errors. One of the things that's important, I want you to pay attention here, right here, workarounds and dangerous abbreviations. We gave you a list of abbreviations to familiarize yourself with. In the textbook, there are do not use abbreviations. I want to talk about workarounds. You will see in the workplace, nurses or healthcare providers sidestep the safety implementations. One of the things that you'll see sometimes in your drug room is they have a tape on the floor that's called the safe zone. If someone's at the medication distributing station and they're doing drug calculations or pulling their meds, if they're inside that safe zone, no one is to come in and talk to them or distract them or answer the phone. Studies have shown over and over again, when there are distractions, the more distractions, the higher rate or incidence of medication errors. It's so important also to make sure you're not tired. We now have guidelines and federal regulations for how many hours you can work in a row, because it's shown the more hours you work, the higher the medication errors go exponentially. So make sure you're following your facility guidelines and practices. And this is just a quick slide. We are providing patient-centered care. Nursing is holistic patient-centered care. You have to work as a team with both the healthcare provider and the pharmacist. Evidence-based practice. Part of quality improvement, and we'll get onto that slide, safety and informatics. These are all of the things that are going to prepare you as a student nurse to practice safely when you get out and practice on your own. So what are the responsibilities of the healthcare team with providing medication administration? Patient safety is your primary goal for providing safe medication. Some studies vary. A Harvard School of Health study found that 3.7% of hospitalizations, it's almost 4%, involve an adverse drug event or an unexpected, where it prolongs hospital stay or causes a disability to the patient. Most of those adverse drug events are attributable to either negligence and are 58% preventable. Another term you're going to hear is sentinel events. Those are recognized by the Joint Commission and are usually related to your high alert medications. Those are medications that if you do not follow the guidelines, you can result in patient death or can cause adverse patient outcomes. The top 5 are insulin. Most facilities require a 2-person check for insulin. Opiates, I can't even talk this morning, sorry. Patient self-administration, PCA, patient care administration. That's your pain pumps. Narcotics, injectable potassium, that's a high alert medicine, and IV heparin. So it is your responsibility to help prevent what FDA has reported 1.3 million people are injured each year and 7,000 die. Some form of error, and think about this, 1 in 5 administrations of medications has some form of medication error. That's the current rate. So, and you have one nurse and she's giving 30 medications through the day. Somehow, statistically, 1 in 5 of those doses given has a medication error. So you have to make sure you have undivided attention. Make sure that you never administer medications in the clinical area without a nursing instructor present. Never administer a medication without a staff nurse or an instructor. That is unsafe nursing care. So back to the expected outcomes. Dosage calculations are accurate. You're going to have a medication competency exam. I know Ms. Qualey's gone over dosage calculations. You're going to review dosage calculations. Make sure, again, you're not distracted. And the medications are prepared using safe procedures. In this part 2 of this lecture, we're going to talk about how do you access medications from a vial? What's the correct protocol for distinguishing landmarks on a patient? So it's your responsibility to make sure that each one of these, that they're accurately labeled. Again, no medication in a syringe or a cup or outside of the container that it's delivered to the unit in should be unlabeled. It should always have a label on it. And then the ultimate goal is that all complications and errors of medication administration are prevented. Now, your patients will say, oh, I know Ms. Qualey's gone over this. There is a difference between known side effects of a medication and a complication. Sometimes we have to give the medicine, for example, chemotherapy, and we know the patient's going to get nauseated. We know they're going to have those known side effects. We treat the side effects, but we don't stop the medication. If they have an adverse outcome or a complication, then you may need to change the medicine. But it's your responsibility as the nurse giving that medicine to know what are the known complications and what are the known side effects and to recognize those. So each person in the healthcare team has specific responsibilities. So what is the prescriber's role? That can be the doctor, a nurse practitioner, whoever the healthcare provider that's writing the order. Their job is to order the medication at the correct dose, fulfilling all the parameters for that patient, for the condition they're being treated for. What is the pharmacist? The pharmacist's role is to prepare those medicines and deliver them to the unit or to the site of administration safely and appropriately for that medicine, for that patient, for that condition, as ordered by the doctor. Many facilities that you work in, you are not allowed to administer an ordered medication until it has been reviewed by the pharmacy. There are certain circumstances where we override that, but it is the job still of the pharmacist to review that patient, review the chart, review the medication, and make sure it is appropriate. What is your role as the nurse? Your role starts with assessment. Assess the patient's ability to either self-administer or when they should receive it. Is it appropriate for this patient to receive it? And to administer the med, and to closely monitor for the effects. That's those known side effects. What do we expect this medicine to do? When I give a blood pressure medicine, do I expect the blood pressure to go up or do I expect it to go down? What are the specific therapeutic effects of this medicine? Assessing the action of that medicine in that patient cannot be delegated. Assessment cannot be delegated. Now, you may speak to your, or address, instruct your unlicensed assistive personnel or whoever's giving a bath. I just gave this medicine. If you see this, let me know. If the patient appears overly drowsy, if they report itching, any of those things. But it is still your job to assess that patient for the therapeutic effect, any known side effects, any adverse outcomes, and did we achieve the goal of the medicine? Okay, so everything has to be done by policy and procedure. Each individual facility will have a written policy, and all of these guidelines are required, and you'll get more of this in your legal lecture, is who's going to give the medicine. For example, the clinical facility where you're going to be going for your practical will say student nurses can give medicine, but only under the direction of an instructor or a staff nurse. What medicine will be given? Certain medicines can only be given, some of your chemotherapy can only be given by a certified oncology nurse. Where it will be given and stored, when it will be given, how confidentiality will be maintained. Again, it is your responsibility to make sure to know what each specific facility has as their policy. Now, we go to lots of different facilities in this. We go to Ochsner, we go to university, all of the different clinical sites that you attend. Each one of them has their own specific policy. I can't address all of those policies in this lecture. Your clinical instructor will tell you what the guidelines are for the facility where you work. Okay, generalized guidelines for medication administration. First and foremost, gone are the days where the nurse would go to the med room, put out 24 med cups, and have everybody's meds in an individual cup, and then go from room to room with those medicines. Your medications should be administered as soon as it's prepared by the individual who prepared the dose. For example, when you go to clinicals, your nurse is not going to hand you a baggie of all of the medicines for that patient. They should remain in the container that they are delivered in by the pharmacy until it's time to prepare it for administration to each specific patient. You, as the student nurse, will go to the med room, you'll pull the meds with your instructor, and then you'll prepare them and go directly to that patient's room to give the medicine. And medication administration record. What is an MAR? Somebody give me unmute your microphone and tell me what an MAR is.
Records of medication.
That is what it's labeled, but what is it? It is a legal document. It is part of the patient's chart. It is where all medications administered to that patient during that length of stay while they're in that care, all medications that are administered must be recorded in the medication administration record. When you document or acknowledge or press the little tab on the computer and say, submit that you have administered that medicine, that becomes a legal record and is submissible in a court of law that you gave that medicine at that time to that patient at that dose. All of it, each step of the medication administration record, each step of your administering it has to be recorded in that MAR. We don't falsify things in the medication record, and we'll go into this further, but it is a legal document. And what do we look at? And I'll get into that in a minute. If in doubt about a medication, if you're not sure if it's the correct dose, if you're not sure if it's the right route, the right time, if there's any question, if it's an incomplete order, you have to contact the healthcare provider that wrote that order. Okay, so if you're in a large university facility and you have residents and medical students, whoever wrote that order, if they're not on call, then you will contact the person who's covering for them. But if you're ever in doubt, don't make assumptions about medication administration. Contact the healthcare provider that wrote the order. Some meds must be verified by another nurse. You're going to hear this over and over again. High alert meds such as insulin and heparin and some of your potassium, all of those are high alert meds, and your facility will say it must be verified. When you're verifying for another nurse, that means you don't just listen to what they say. You look at the MAR, you look at the container that it's in, you look at it when it's drawn up in a syringe, you verify that that is the dose. Because in that MAR, if it's a high alert med, you have to put your own individual electronic or physical, if it's a paper MAR, your responsibility as the second person verifying is to put your official signature and verify that that's the medicine. And the Joint Commission says, according to all their national patient safety goals, you're going to see, what do we say? 2 patient identifiers. You hear the patient state it, you look at the armband, and what are we going to ask? What is the most standard 2 patient identifiers that we ask for?
Full name and date of birth.
Name and date of birth.
You don't tell them what their name is. You say, "What? Please state your name and date of birth." I try and always do it while I'm looking at the armband. When you go to most facilities nowadays, before you, even though you have the barcode scanner, you're still going to require that patient to state their name and date of birth. And that's the 2 patient identifier. And then the 6 rights. And we'll go on, there's another slide, and I know that in her legal lecture, she said 7, but we'll see how that relates. I want to go back to the MAR. This is, and I've got to move my, I want to move it so I can see the whole screen. This is an example of a paper medication administration record. First of all, with the MAR, before you ever administer any medications, you've got to do what? You've got to go to the order sheet, whether it's paper or electronic, and you have to compare what's currently on the MAR with what the physician's orders. Many times orders will change. One of the things, first thing you're going to do is you're going to look at the MAR that you're on, and you're going to see, and this one doesn't have it, but it should have that day's date on it. And this one may be buried under the screen. So MAR runs for a 24-hour period. You can see it starts with 0, 100 and goes up to 2400. These, and it's hourly increments. Each medication that's going to be delivered, administered, it includes this one has both the trade name and the generic name, the dose, the route, IV piggyback, given over 30 minutes every 12 hours. That's the administration record. And later on, we'll see, this is an example of it starts on 9/6 and ends on 9/13, because we only give it antibiotics and a lot of anticoagulants. You give it within a specific, only for so many days. Over here, you see famotidine and Pepcid. It's 20 milligrams oral. BID, that's twice a day. Start, that gives the first day that they gave it, but it doesn't have a stop date, so you continue to give it. And you'll see here it gives 0600 and 1800. Those are the scheduled times. So over here we come and we see they put an X that at 0600 and they repeat 0600 and they put their initials. The person who administers that medication enters their initials. Now, if there's ever any documentation or in the MAR and you have to put your initials somewhere on somewhere on that sheet, you sign your name and put the initials that you're entering into the MAR. The other thing that's important on your MAR is it includes the patient's name and their physician and their room number, their age. I think it's on the bottom of the page that you can't see on this screen. And it will include their admitting diagnosis and any drug allergies. One of the other things that's important to look at on your abbreviations that are acceptable to use on the MAR, if you're administering an injection and it's the left upper outer quadrant, sorry, my mouse keeps disappearing, that would be entered. So if you give an injection into the subcutaneous tissue of the left upper outer quadrant, which would be, and it doesn't have it, you would enter an A as additional in that slot where you administered that medication. So always know what your language, your abbreviations are. And again, your responsibility as you're looking at the MAR is to know what is the patient's current status and are all of these medications still appropriate for this patient. And this is skill 2.1. This is an picture of an electronic MAR. I know a lot of our facilities use Epic. I'm not allowed by copyright laws to take a picture. That's often a question. But it still contains the same information. It has the patient's name, his room number, the unit he's on, his medical record number. Most of them in the electronic MAR, it will include their weight, height and weight, and their BMI. It includes their diagnosis, but often what you also have additional information in your electronic MAR is directions such as crush all medications, what assessments need to be completed before you administer these medicines. So each medicine is still listed most of the time. There we have the generic name penicillin, which is Vcillin, 250 milligrams, the route oral 4 times daily. And you notice they do not use abbreviations in this example. The start date was August 26th, and the time when the first dose was administered at 1300. One of the things that you'll see is they're often color coded. So if it's a PRN medicine in Epic, they're in blue. If it's a regularly scheduled medicine, sorry, it's blue, but your clinical instructor will orient you to that. But it will also have codes or alerts. This medicine was due at 9 o'clock. It's now 10 o'clock and it hasn't been given. And then what is the next one that's up? And you can, oh, sorry. Oh, go back. One. Okay. The other thing that we'll have is it does have the current date that you're working on, and it has the shift. It divides it by shift. If you want to, and this one is looking at all of them, or the scheduled or the PRN, and you can just pull up and click on which medicine you're looking for. Hold on. Okay. So what are the 6 rights? Each medication that you give, you have to follow the 6 rights. And that recognizes the right patient, the right drug, the right dose, right dose, sorry, the right route, the right time, and the right documentation. I know that in her lecture, she had put the right assessment. That is knowing the right drug, subsets of the right drug and the right dose. So again, you have to know the right patient, the right drug, the right dose, and each one of the 6 rights. Sometimes patients will have more than one healthcare provider writing medication orders. If you have, for example, in a trauma unit, you can have the GI service, the orthopedic service, the neuro service. Is your responsibility to review those orders and compare it with the MAR to make sure that it is correct. If any medication order comes up because it's illegible, incomplete, contact the healthcare provider who wrote that order before administering the medicines. So, medication allergies. Different facilities will have different alert bands and different colors. Some of them may write, if you see here in this picture, the patient has ASA and some other medications that are specific. This one has just allergies. It's your responsibility to go back and look at the medication record or the patient's chart and make sure that you know what all of their allergies are. If they're coming in, they're being admitted, many times you'll see they'll have a medic alert bracelet, or if this is a patient who's outside the inpatient care area. It's your responsibility to assess that patient. If they have a medicine one time and they can develop an allergy the next time it's a given, each time you administer medication, it's your responsibility to say, do you have any allergies to this patient, to this medication? So what are the additional rights? This is where you see the right assessment. Many medications, such as your anticoagulants, you have to know what is the lab value that I need to know before I give this medication. What are there any specific tests that need to be done before I give this medication? Is there a vital signs before you give digoxin? You've got to know what is the apical pulse rate of that patient. If you're giving a blood pressure medicine, what was the most recent blood pressure medicine? Was it too high or was it too low? What is the correct assessment before I give this medicine? Then as you're administering the medication, it's your responsibility to know, to talk to that patient and say, this is the medicine I'm giving you. What have you had it before? And to know what you need to teach that patient. The patient needs to know what are the intended therapeutic effects of that medicine? What are the expected side effects? What do I need to report to the nurse after I give this medicine? What are the known side effects? Patients also have the right to refuse. And we have patients that have a right to self-determination. Sometimes if you have a patient who's confused or doesn't understand the therapeutic, they may need additional education. Why is the doctor ordering this medicine? But they have a right to refuse. I worked in a long-term care facility where the patients had a right to refuse, even though they're confused. And so the nurses would mix all of the medicines with a chocolate syrup and say, here, do you want your candy? Because if you went to them and you said, oh, this is your blood pressure, I don't have a blood pressure problem. So again, sometimes you have to get creative with the patients, but they do have a right to refuse. And then the right evaluation. How do I know if this medicine is achieving the therapeutic effects intended by the healthcare provider that ordered it? I have to know for each med, what is that medication supposed to do? And another thing that's so important with the MAR, never document a medication you didn't give. Always, if you make an error, so for example, if you give a patient, you document that you're giving the patient the med, and then you give it to them and you've already clicked on it, you can go back and correct it and say patient refused the medicine, because you have had those instances. But just so you know, an electronic record, especially in the EMR, each time you enter that patient's record, it is recorded. So never falsify. And again, on your documentation, the name of the medicine, the strength of the medicine, the route given, and the response of the client. That's your responsibility to document. So let's take, and again, this is supposed to be a poll, but I'm having trouble with the poll. So let's just look at this. The nurse administers a home medication to the client who states, that pill is not the same color as what I take at home. Which response by the nurse is best? A, encourage the patient to take the medication because the nurse performed all the safety checks. Is that the appropriate response? Or B, hold the medication until the nurse has double checked the order, the medication and the patient. Or C, inform the client that it's safe to take because different generic forms of the same medication look different. I know what.
B.
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 Yeah.
B. B.
B. That is correct. After you've double checked, you can encourage that patient to take the medicine and say, yes, I did check with your doctor and this is the correct medicine to give. And that you can say, I did double check. This is could be from another provider, pharmacy or manufacturer, because they will change based on, sorry, let me get a drink. I'm having a little frog this morning. I think it's with all of this rain. So that is always correct to double check when they question whether or not you're giving a med. I have a son who has autism, and we changed the medicine, and he went to school and the school called and said, this child's all over the place. So we thought he was having an adverse reaction to the medicine. I called the doctor. We went through all of that to see what we could do. And then I got home and I found it sitting on the kitchen counter by his cereal bowl. And I said, why didn't you take it? He said, it's the wrong color. I don't take that. So also it can be important. Well, the color that you were taking is a different med and the doctor changed it, but always double check and educate your patient about the medicines that you're giving. Oh, and then do not administer the medicine and assess the patient. You may have a confused patient, but always double check when they say that. Okay. So This is an example of a handwritten physician's order. All physician orders have to have complete information. Who can write the orders? In your current healthcare facilities, it can be a medical doctor, a doctor of osteopathy, a nurse practitioner, or a pharmacy assistant. It is your job, and I know Oshner encourages you to know, where can I access the list of healthcare providers that have privileges? And that's knowing who has privileges in the facility where you're working. What are the 7 parts of a medication order? That's box 35-1. How do you know if an order is complete if you don't know all of the parts? It's the patient's name. Here you see it, Jane Clary. The date and time the prescription was ordered, November 1st. The drug, it's tetracycline. The dose, 250 milligrams. The route, PO. PO is the abbreviation for by mouth. The frequency, 1 daily, and then the signature. On a prescription order to go to the pharmacy, it also needs to have any specific instructions for administration and a dispensing amount. So this includes dispense 30 pills and take on an empty stomach. Where should orders be written? We have gone into most facilities now have electronic order entry, and you will find it on the patient's chart under physician's orders or orders for that patient. A lot of doctors' offices are not even giving handwritten prescriptions, they're faxing over orders. So if you're in the acute care, most of them should be entered on the electronic order entry. Now we're going to look at an example of handwritten orders. For example, if you have a power outage, you have to switch to a physician's order sheet. Or if you receive a telephone order, so your healthcare provider giving the order is not available to enter the electronic order entry, then you may have to write a written order. All orders must be written on the physician's order sheet. They cannot be written on the progress notes or on the consult. They have to be written on the physician's order sheet. So what are verbal orders? As I said, if there are occurrences where the healthcare provider cannot get to the electronic order entry, that's when you, as the nurse providing care for that patient, have to take verbal orders. And you saw a video of this in your SBAR demonstration. So we're going to practice our SBAR communication. The doctor's going to tell you the drug, the dose, the route, the frequency. It has to have all of the patients. You're going to state, you're ordering for Mr. So-and-so, and you're going to document the date and time, the drug, the dose, the route, the frequency, and who's giving the verbal order. Some places will have you document a verbal order as a VO or a TO. And most facilities have policy and procedure that say all verbal orders have to be countersigned by the healthcare provider writing it within 24 to 48 hours. It depends on your facility's policy. So there are specific protocols for receiving verbal orders. You can take verbal orders. I know in the operating room, when I was working in the operating room, they'd have a patient that was getting critical and the doctor scrubbed in and can't. And so I would relay the message between myself and the nurse providing care, or the nurse taking the verbal order. In that instance, they would take my name and state that I was relaying that information. All of that has to be documented when you're giving verbal orders. And to do that check back, a lot of facilities have also given written guidelines that say, if the healthcare provider giving the order is standing there, you're not to take a verbal order from that they can enter it in there. If they're in person, they can write the order themselves. In what system should orders be written? They should be currently in this country and around the world, it should be written in the metric system, not the apothecary system. Apothecary is your standard. There are times, though, that you'll use a household measurement, such as if you're giving instructions to a patient and they need 15 milliliters equals how many teaspoons. You're going to tell the patient to administer teaspoons when the doctor writes the order in milliliters. But for the orders, it should be written in the metric system. Should generic or trade names be used? You're going to find when you get out and practice, you're going to have both. The doctor may know it only as the trade name. You go to the Pyxis and it's only written in the generic name. Sometimes you have to have either a resource, or I have, even when I was in a hurry, the doctor says, give him this, and I don't remember the generic name and it's only dispensed generically. In this program, we use only generic names because your NCLEX exam is written in generic names, not trade names. What abbreviations are acceptable? So, in each facility, per Joint Commission guidelines, you should have a specific list of do not use abbreviations. There are examples of what are acceptable, and that's in table 35.6 in your textbook. We're going to go over some of those in a minute on another slide, but your responsibility is to know what abbreviations are and are not acceptable. And that's in table 35.6. So let's look at administration scheduling. Again, it is up to you to know what is my facility policy where I'm working, where I'm administering meds. So for example, most medications where the doctor orders it to be given daily, the standard time to give that is 0900. 2 times a day, which is the accepted abbreviation of BID, that would be 0900 and 2100. 3 times a day, or TID, is 0900, 1400, and 2100. 4 times a day, acceptable abbreviation QID is 0900, 1300, 1700, and 2100. If the order is written every 3 hours, if it starts at midnight, there it is, midnight, 0300, 0600, 0900. Those are specific designated administering times. So it's up to you to know how did they write it. So if it's daily and you have your nurse and you have 6 patients and they all have 9 o'clock meds, can you be in each patient's room all at 0900? No. So recognizing that medication errors were being committed because the nurses were stressed. I've got 6 patients, I can't give them all 0900. Each facility has developed a specific guideline for how far outside that 0900 you can give that medicine. For example, on the unit where I take my students, on Ochsner Health, it's Ochsner Health Clinic, they say that if a medicine is ordered at 0900, starting at 0801, or 1 hour before that designated time, or 1 hour after. So I have from 0801 to 0959 to give that medicine, and it still be considered to be a correct time. It's given within the ordered time and is not an adverse or an incorrect drug administration. So I can get, starting at 7:30, I'm going to start getting all my 9 o'clocks and figure out who has an additional medication and start administering so I can get all 6 patients administered. Excuse me. Now, it still is important even though it's a 9 o'clock medicine and you're giving it 0801, you don't document that you gave the 9 o'clock when you gave it at 081. And why is that important? Because when you come down here and you have a patient who's supposed to receive that medicine 3 times a day, or say every 3 hours, and this medicine is actually given an hour before, and then but they documented that it's given at midnight, and then the next one comes along and they look at, oh, it's given at 0300, I have an hour, but they don't realize that that first medicine was given actually an hour before, and you can have a 2-hour gap. And the reason they order these medications every 3 hours is so you receive the intended therapeutic effect. You have peak and trough times. You had all that in pharmacology. So it's important to remember to document the exact time. And when you're getting ready and planning your day and looking at your orders and your MAR, look and see, when did they receive the last administration? And it will show in your MAR, when was the last administration? So you want to achieve the therapeutic effects, okay? If a medicine's to be given every 24 hours, so say they're in the emergency room and they come in at 1 o'clock in the afternoon, and then meds administered at 1400, then that means that every 1400, the antibiotic has to be given based on when it was first administered. Bedtime can depend on the unit you're working on. It may be 2100, it may be earlier. It's important to know when the patient is and when that facility or that unit's normal bedtime is. It usually means that the patient needs it to go before they go to sleep. And then with meals, here you have 0800, 1200, 1700. That's going to depend on the meal delivery time that your unit receives. Some meds have to be given before that first meal. So it's important to know what the patient and what your unit is. Okay, and again, injectable antibiotics, it depends on when that first medicine was given. So here we have abbreviations, and this is some of the approved versus the unapproved, and you should review table 22 and 35.6. These are all medication abbreviations. Okay, and it's important to familiarize yourself with these. So back to the different types of order. I want you to look at this. This is a handwritten doctor's order form. So all written orders have to go on the written order form. You'll see it has their name and it has their medical record number. It has the date and time and the signature of the person administering or ordering the med. So usually they have a specific order they write the orders in. So complete bed rest, TED or TED host to both legs, regular diet. And I want you to look at these medication orders. It has the drug, Benadryl, 25 milligrams, PO or by mouth, Q4 hours, PRN for itching. So any PRN medicine has to have the parameters. There's your drug, your dose, your route, your dose, your administration times, and then the parameters. Here's heparin, 2,000 units sub-Q, Q 12 hours. One of the reasons we've gotten away from handwritten orders and everything's electronic order is because you can have people with sloppy handwriting, or if they someone misinterprets it, then it can cause an adverse drug reaction. That's why it's important for you to know. Heparin, is it usually given for this patient, for this condition? Is that a standardized dose for this drug for this patient? And to question, anytime you have a question about an order about handwriting. And then they have additional orders down below, and that's one form of a specific of handwritten orders. So what are the different types of orders? And these are from page 760. A standing order, those are your daily doses, ASA or aspirin, every day. Those are medicines that is carried out until it's either canceled by another order or the prescribed numbers of days end. Some facilities, such as long-term care or acute care that are rehab, they'll say an order has to be renewed every 30 days, standing orders. It depends on your hospital facility, or a standing order can be as long as the patient is in this facility. It usually indicates a final date to be given or a specific number of treatments. Maintenance medications written for home dispensing may or may not have an end date written into the order, but those are standing orders. A stat order is an order that signifies one-time dose of that medicine to be given immediately and only one time. Different facilities have different orders for the time frame. Some facilities say within 30 minutes, some say within an hour. It's going to depend on the facility. Remember, we're using generalized. So we're going to say it's a one-time order to be given immediately, as soon as possible, or within 30 minutes, because that patient's deteriorating condition or changing condition requires a stat order. A single order is an order that's given one time, but it doesn't have to be within that 30 minutes. For example, give an antibiotic prior to surgery. Give blood. Blood is a one-time order. You never repeat it. Or to be given one time at a single time. PRN orders. Those are orders that indicates that it is only to be given when the patient requires it. So what does this PRN order say? It says PRN or as needed for itching. So the parameters you'll see down here. This is an example of apothecary. ASA grain 5, that should be written in metric. PO for a temp, and that should be PRN for a temp greater than 101. If the patient has a temp of 100, do we give the medicine? No, because PRN orders have to follow the parameters as written in the order. And then you have combination orders. There are specific times that two medicines have to be given with each other, because what? They either potentiate each other or one protects one from the side effect of another. If a patient, if they're giving blood and then they say give the Benadryl at the same time, but I have some examples. So here is a combination PRN order. Demerol, 50 milligrams IM or intramuscular, and Phenergan, 25 milligrams IM, intramuscular, every 4 hours PRN for pain. Can we give just the Demerol by itself every 4 hours? No. Can we give the Phenergan? No. You have to combine the two drugs at the same time as written in the PRN order. Sometimes it can be confusing, so the Joint Commission has entered some that are not allowed. So here is a combination PRN order. This one actually is not a combination order. This is a PRN order. Demerol, 25 to 50 milligrams IM every 4 hours as needed for pain. Can we use this? It should not be used. Instead, you have to have specific. Demerol, 25 milligrams IM every 4 hours as needed for pain, rated from 1 to 5, or Demerol, 50 milligrams IM every 4 hours for pain, rated from 6 to 10. Can you, as the nurse, give Demerol 25 for pain rated 6 to 10? No, you have to follow the specific parameters. Can I give 50 milligrams for pain rated 1 to 5? No, you have to follow those specific orders as written. The final one down here at the bottom, Demerol 50 milligrams every 3 to 4 hours as needed for pain. No, it cannot be every 3 to 4. It has to say either every 3 hours or every 4 hours as needed for pain. And more than likely, you're going to see every 4 hours because what is Demerol? It's an opiate, and we're trying to be opiate stewards, good stewards of the narcotics that we're given. It has to be specific time frames.
Miss Cook, it's 10:30.
Okay, this is a good place to stop. Thank you, Ms. D. And I have to hit the escape button because I can't see. We'll see you all back. I don't see a time. 10:30.
It's 9:30.
Oh, it's 9:30. Yes. We're going to take a 10-minute break. Okay. And we'll see you back at 9. What time is it? I have 9:30. So meet back at 9:40.
Sounds good.
Oh, okay. Thank you all. All of a sudden,
Ms. Cook,
yes, go ahead.
I have a question. So back on the slide where you were talking about acceptable abbreviations versus unacceptable abbreviations, you said acceptable abbreviations was listed on table 2-2. What book is that coming from? Because I don't have that in my fundamentals book.
It could be the, it should be your concepts book. I know I looked those all up before I put it in there.
Okay, so it's the concept book.
Forward to it. This is where we were. I'm sorry, I'm getting, all of a sudden I don't see anybody's screens. Doing the recording. Thank you.
Excuse me, Professor Keller. I had to swap computers and I'm having a problem with putting my section number on.
So what did I tell you to do?
put it
Miss
in the
George,
chat.
Miss George, what did I tell you to do if you're having a problem?
I tried to log.
Okay.
Hey, Ms. Cook, this is Michelle Dufresne.
Hey, Michelle.
Hey, am I supposed to be lecturing after you?
No, I have the full 2 hours.
Okay.
Yeah, because I have a 4-hour lecture. Okay, so I think I'm recording. It's hard to tell on this screen.
You are.
Okay, thank you all. So automatic stop orders, there are specific times, excuse me, when you have medications that have to be, you have to stop and rewrite the order. And these are by Joint Commission standards and other medication, the FDA. So when you're transferred from one service to another, so for example, a patient comes in the morning for 1-day surgery or comes in for surgery that day, they have a set of orders. When they're transferred to the OR, they have to have a new set of orders. When they're transferred to a recovery room or PACU, a new set of orders. When they go from the ICU, then or down to the step down unit, each time they change service, they have to have a new set of orders. So orders for routine meds are good for 30 days or the length of hospital stay. We talked about that. Those are your scheduled daily standing orders. Certain meds are out of date automatically, and then you saw those on the MAR. Antibiotics are usually given, if it's a prophylactic antibiotic, we give prophylactic antibiotics in the OR to help prevent surgical site. Those are usually there for 48 hours. It's important to know, is this a treatment antibiotic or a prophylactic antibiotic? So the pharmacy will indicate it starts on this day and it ends on this day. Hey, I just thought of something. You're probably supposed to be in the other group lecturing, Michelle, Miss Dufresne, because Kathy has a 1 hour, I have a 2 hour, and you should be in the other team, group B. I just now realized that, thinking about the automatic time. So antibiotics, anticoagulants, whether they're PO, sub-Q, or IV, they will have a specific time frame. Give them for 2 hours or give them for a week. It depends on the controlled substances. Nowadays, the standard is for narcotics, we're only giving a 3-day order. Then the doctor has to write a new order for additional pain medicine. And then there is a term that you're going to hear over and over again in the healthcare field. It's called medication reconciliation. It's a recommendation by the Joint Commission, and that's in box 35-4 in your text. What medication reconciliation is, they say that if a patient comes from the home and they have medications, it is the healthcare organizations and most places assign it to the nurse to look at all of their home meds and determine what ones are coming over. When they go home from the hospital, you have to determine from the healthcare provider, which of these meds do you want this patient to continue at home? And you also have to send notice of the medicines they're discharged home to the primary care provider, because what was happening, they were coming in the hospital having all these meds, the doctors would change the meds and they go home and the primary care provider has no idea. So to prevent that, we now have a process called medication reconciliation before you, when you receive a patient into a healthcare agency or before you discharge them home. It is your job as the nurse providing care to complete the medication reconciliation process. So, specific guidelines, administer and document only those medications you prepare. You don't accept a syringe that's not labeled or meds in a cup that aren't labeled that you have not prepared. I personally was involved in a situation where they handed me a syringe and they said, this is the dose, and I gave it. And then they said, wait a minute, you're giving a whole cc. I said to give, but when they handed it over, they told me, they said a different dose is what is that. So only administer and document those medications you prepare. Check your patient identification over and over again. Remain with the patient. What are we talking about? So you go to the patient's room, they're in the bathroom. Do you stay there and wait? Depends on your patient, depends on your schedule. Most of the time you're very pressed for time. You cannot leave those meds sitting on the bedside table. You can't leave them with the family member. In the acute care setting, you have to watch the patient take the medicine so that you can document that at this time. So say for instance, the patient's in the bathroom, you've left it on the med, they get sick, they come in, and now it's an hour later, it could be an hour or more later, and you documented that you gave it an hour before, and then think about your scheduling time of that medicine. You have to remain with the patient and be certain that they give it. Omitted medications. There are certain times that a patient may be off the unit. Say they go to x-ray or down to cardiac cath lab or to the endo unit. Anytime you have a patient that the meds are not administered within that designated time, so the 9 o'clock time or your 1400, when that patient returns, you'll document that you won't document in the MAR. Remember, the MAR is just for meds that are administered. You can document in the progress notes or in your nurse's notes, patient off unit, these meds were held. When they return, depending on the amount of time, it's your responsibility to go back to the healthcare provider and say, he was off the unit, he was supposed to be gone 30 minutes, he was gone 4 hours, which meds do you want me to go ahead and give? Because otherwise, when you go into the MAR, it's going to say you made an error giving that med outside the ordered time. Now, when you have a med, the patient comes back and the doctor says, go ahead and give that 9 o'clock med at 2 o'clock or 1400. It is your responsibility. Almost all of the electronic MAR has a comment box before you, when you're documenting, you're giving that med, say patient off unit, or it will pop up a box. You're giving this outside the designated time. Why are you giving, and they'll give a drop down box for choosing patient off unit, med not given, or patient was NPO. So it's your responsibility to document the correct time and why it wasn't given at that time. The documentation, again, all documentation goes on that medical administration record, whether it be handwritten or electronic. Only persons actively receiving medical care can be given. So you have a patient, his wife has been there night and day with him, and she says, I've got a headache from all the noise in the hallway. Can you give her Tylenol? No, only patients who are actively receiving medical care can be given medicine. And then medications brought by the patient to the hospital. There are certain meds that patients have that are either, so say you have a patient has an inhaler, a bronchodilator, and they bring it with them and they're here for surgery. They're not being treated for the pulmonary issue, but they're bringing it from home. Before you give a home medicine, you have to get a doctor's order to continue the home medicine at home. Depending on the medicine, you may leave it at the bedside for the patient to self-administer, or they may move it to the, but you have to verify with the pharmacy what is the policy for that home medicine. Some pharmacists want you to send it down to the pharmacy and they'll put a hospital label on it before you can give it to the patient. Always verify. And if the patient is self-administering, in the MAR, you say patient reports self-administering or patient witnessed. Always document accurately on those medicines that may be brought with the patient. So, excuse me.
Ms. Cook, I just wanted to confirm, so if a patient brings their medications from home, we cannot give them that medication unless a doctor has an order for it?
Yes.
Okay.
And so you'll say, doctor, he's got this special high blood pressure medicine and it's not in our formulary. Do you want them to receive it? Contact the healthcare provider. Okay. And then they'll enter the order and then it'll enter on the MAR.
Okay, thank you.
You're welcome. So medication errors. We want to talk about all of these guidelines, all of these rules are to help prevent medication errors. Studies have shown over and over again, it's usually a system error that results in the patient receiving either the wrong drug, the wrong dose, the wrong time, or the wrong route. I know you just saw in the legal, Miss Chairs, I believe it's Miss Chairs, about the nurse who was brought up on criminal charges for administering the wrong medication. That's a change in our the current political environment. Used to be they'd handle it through the medical board or the nursing board, and they would be the ones responsible for correcting or either pulling your license or putting you on suspension. Moving it to the criminal, that occurred, I think it was in Canada, I think in the last 10 years. But again, we want to prevent it because, for example, there was Dennis Quaid's little babies. They received the wrong heparin dose. And I know that at St. Vincent's Hospital in Indianapolis, Indiana, on one shift, there were 4 babies that received an adult heparin dose and died from receiving the wrong dose. I know that St. Vincent's Hospital recognized it was not the individual nurses. There was a system error. And so Not one of those nurses, they were put on, like police officers, they were put on administrative leave. They were put on leave until it could be investigated. Not one of them lost their job. But can you imagine how you would feel if you were the nurse that administered the incorrect heparin dose and caused a fatality of someone's child? That's the seriousness that we're talking about. And that's why we look at continuous quality improvement. You are responsible not just for your actions, but for the actions of the pharmacy, for the actions of the healthcare provider. That's why we've moved to electronic medical records. That's why we've moved to the automatic dispensing systems. Each point where there's human interaction, it can cause, you can look and find medication errors. That's why it's important for you to know all the correct steps. So when you see an incorrect situation, you can report it and address it and help prevent a medication error. For example, I went to pull lidocaine out of our Pyxis, and I needed it lidocaine without epinephrine. They include the epinephrine so it's absorbed quicker. The pharmacy tech was loading the system, and I said, oh, wait a minute, you're putting that lidocaine in the wrong bin. She was putting the lidocaine with epinephrine in the bin. She goes, well, that's all I have. Ding, 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 ding. That is a big red flag. They're loading the wrong drug. And that's what happened in both the Dennis Quaid situation and that St. Vincent's. The pharmacy tech loaded adult dose heparin into a pediatric unit. The nurses were either too busy or too distracted. Something happened that 4 times in one shift, the nurses did not double check that dose of that high alert medicine. So always high alert medicines, double check, don't take any shortcuts. If you see potential, and I've got some examples coming up, for medication errors, it's your responsibility as a professional nurse to step up and speak out so that those can be addressed.
If you saw someone doing something like that though, like, would you have to report it right away, or could you just be like, dude, you're doing the wrong thing, and then if they change?
I got on the phone right away and called the pharmacist. Yes.
Okay, so you don't just tell that person to their face, like, hey, you're doing the wrong thing.
I told her, and she ignored me.
And if they don't ignore you, do you have to go to their superior?
I just told like I said, I called the pharmacy. I said, I just witnessed it. We've got the wrong dose. I wasn't ugly. I said, the wrong medication is in this bin.
Okay.
Okay. It depends on the situation. It depends on the attitude. You have to, know within yourself. And later on in the shift, I did go and let my supervisor know what happened. So I didn't leave it just at that. I let her know what had happened. Okay. But again, you're right. It is everyone's responsibility to watch for each other because either she was in a hurry or whatever reason.
Okay. I have a question. Should you let your supervisor know first? Like you're supposed to let your supervisor know first before you call the...
And that day that it happened, I happened to know that my supervisor was in a staff meeting off the unit.
Okay.
So it depends on the situation, depends on your role. I was the team leader that day. So technically with her off the unit, I was the supervisor. Okay.
Okay.
But to look out for those things. Thank you. That's a good question. So what happens when an error occurs? If it's the wrong patient, wrong drug, wrong dose. As soon as you recognize there's an error been made, what should you as the nurse do? What's the first thing you're going to do?
Report it.
No, you're going to go watch that patient and monitor for any adverse outcomes. Your patient is your first responsibility. Okay, sorry, that wasn't the slide I thought I was going to. Your patient is the first responsibility. Check and make sure your patient, say you gave a medicine that they're allergic to and you didn't realize it because it was for whatever reason you didn't realize they had, you've got to monitor that patient. That and giving a patient they're allergic to can be a life-threatening. First of all, make sure that the patient's safe. Okay, monitor, because you've got to watch for any adverse outcomes.
Ms. Cook,
Yes.
is there like a certain amount of time that adverse reaction would happen?
It's going
like how
it's going to depend on the drug, the route delivered. You know, remember, we're going to get into it. IV medications, they're effective within 2 to 3 minutes. Sublingual, within seconds. PO meds, they're within 30 minutes. Okay. So it's going to depend on the drug, depend on the route delivered. And it can depend on the error. So in my mind, I'm thinking a lot of times it's the wrong time is those 1 in 5. So you got in the room and the patient's talking and it's your last of your 6 patients and you thought they'd be easy. And so all of a sudden you're trying to get them checked in and they've got a family member and you wind up giving it at the wrong time, you know, just past outside that 1 hour parameter. You see what I'm saying?
Yes, ma'am.
It depends on the error and depends on what you expect the patient's outcome.
Okay.
So a lot of times, like with that wrong time, if it's 1 minute past, me as the clinical instructor, and I will document in the MAR medication given outside, and then I report it to the nurse that is actually giving care. And most of the time they'll say, yeah, okay, I've got it. And you don't have to contact them. But again, it depends on the medication error and what's going on with the patient.
Okay,
But
thank you.
always assess your patient first.
I also have a question, Ms. Cook.
Okay.
So you give a patient a wrong medication or the wrong dose of a medication, and this medication requires like an antidote. Do you watch your patient first for adverse reaction and then go get the antidote, or should you get the antidote first and then watch your patient?
If I have a patient that I'm trying to get an antidote into for the wrong medicine or the wrong dose, first of all, we don't carry the antidotes with us, but it should be available on your unit. I'm going to call for help and say, I need someone to bring me to this room. I'm not going to leave my patient. I'm going to call for help or bring me the antidote.
Okay.
I know in the recovery room, which is where I worked most giving medicines, we had them already ready to give because we're giving high doses and more frequently, like every 15 minutes. One of the longest 90 seconds of my life was I gave a patient, a little 7-year-old, morphine, and he went into respiratory arrest on it. And that was it seemed like a lifetime at the time it was happening, where we're waiting for his breathing to come back. But when you go back and look at the monitor, it was only 90 seconds that his respirations were down. Come to find out, he had a family history of allergies to morphine, and nobody told us ahead of time. So, but again, it's going to depend on your location. And you should have a list of, anytime you're given a medication, especially high alert, you should already know what is the antidote. In your pharmacy, I know she told you what your antidotes were. What's narcotics, Narcan, you know, what is the antidote for your warfarins and your heparins? You should already know before you give that med what's the appropriate antidote. Okay. So it's part of the continuous quality. This is the Institute of
Ms. Cook.
Yes.
Should we review the drug allergies before we give a new medication?
Yes, absolutely. So I want each of you to recognize the Institute of Safe Medicine Practice. This is an organization that is developed to look out for medication errors. You should sign up for their newsletter. These were all alerts that came in a recent newsletter. It's actually been a year ago now. And you, as a professional nurse, they will send you notices when these things occur. The other thing they ask is, there are times you have near misses. So what they're asking is for all professionals to, if you have a near miss, to report it to them so they can study it and get it included in their database. So for example, one of the things that came up is this Bredion. It's a medication that you're going to draw up in 200 milligrams in 2 mLs. So that means you're going to give less than 1 ml. Excuse me. So you draw it up out of the vial, and then they provide stickers to stick on your syringe, so your syringe is labeled, correct? And you'll see this in heparins or in insulins where you have a multi-dose insulin vial, and they'll provide labels. One of the problems was they realized that this label dose did not match the dose on the actual vial. And it was nurses that discovered this that reported it. One of the other things they noticed, because they study it, is this medication that nurses kept overriding the barcode scanning because they couldn't get a good, accurate reading. What they discovered is it was written on a curve on the vial, and it wouldn't, the barcode scanner couldn't pick it up. So then the company came back and changed the barcode to being an up and down solid on one thing. And so they sent out the notice, look for and return any barcode, any vials that have the barcode on the curve. Then this is one, verapamil and naloxone. Those are, that's your antidote. They had two identical, very similar, they're different manufacturers, but two different drugs that were in look-alike vials, and there were errors that were made. Again, and we're gonna go into our triple check. And then one of the other things they recommend, if you're labeling it, or if you have a medicine that has a high alert med, to put it in your high-low letters. So they switched it from being tear off to being single stick so that you would have all of the information included. So they recommend using the high alert fentanyl versus another med, which is sufentanil, and it sounds like fentanyl or sufentanil, but one is 100 times more potent than the other. So always make sure that you're using the correct label when you're relabeling syringes. But they recommend using don't write on a piece of tape and stick it on your syringe or on your vial. Always use the pre-printed labels. So, similar, I've got to hide my screen, my floating controls, so I can see the top. So, factors that are similar with medication errors. Similar names or packaging. So Clonazepam versus Ativan, those are the generic, but their trade names are clonazepam and lorazepam. Very, very similar. Look for your look-alike, sound-alike drugs. Or clonidine versus Klonopin. That's Catapress versus Klonopin. So look-alike, sound-alike drugs. Make sure you're getting those. Or medicines that are not commonly prescribed. If you have a medicine that's a new medicine that you've never given before, then, excuse me, that you've never given before, look up, know what your common dosages are, what is provided, is it appropriate for that patient at that dosage rate? One of the other things that are listed that is known common mistakes is accidental daily dosing of a medicine that was intended for weekly medicine. And that happened because I know a big case where the family got awarded $6 million because the patient came into an oncology unit. He was there a day early. The doctor went ahead and gave him his treatment while he was there, but didn't document it in the MAR. The patient went home, came back the next day for his regular dose. The nurse didn't know the doctor had given the dose before and gave him another dose, and he went into renal failure and died because the doses were too close together because it didn't get documented in the MAR. Those are known cases. So this is what we want to look at. These kind of data. This is important for you to know.
Excuse me, Ms. Quinn. So in that case, who's the fault? Is that doctor's fault because didn't tell the nurse?
Yes.
Or the
jury decided.
Okay.
That's what the jury decided. There were
Okay.
some other mitigating factors, but that's what the jury decided. Okay, somebody go ahead and mute. Thank you. So other types of events for medication errors are more than likely medicines given up, medicine that an antibiotic. Again, anytime you have a medication allergy, you're going to ask the patient, do you have any allergies? If so, what was your reaction? What was the allergic reaction? Sometimes people can say, I have an allergy to Toradol, but it would upset their stomach. Is that a true allergic reaction? Sometimes it's a known side effect. Sometimes it's allergic. It's your responsibility to know what are the allergies. Opiates, non-steroidal anti-inflammatory drugs. Patients can have, those are the most common medications for allergies. Other things that can cause medication errors is if you have the wrong weight on a patient. That's why it's so important when the patient is admitted to the hospital, you get the daily weight, know and show. Because if the doctor's ordering the medication based on a milligram per kilogram nomogram, and the patient's had a drastic weight change, you may give an inaccurate dose. Again, if you're teaching the patient what is 15 milliliters, and you may have to know, you should know how to convert milliliters to tablespoons or teaspoons. It's important that you instruct the patient, that's teaspoons, that's 15 milliliters equals teaspoons, not tablespoons.
Ms. Quayle, we don't need to know the household measurements anymore.
You said that. I know Ms. Quayle teaches that, but you will. She teaches that in the pharmacology course. But if a doctor teaches you, if a doctor gives an order for 15 mLs, how are you going to tell the patient that education? Okay. There are times. Okay.
Yes, ma'am.
Thank you. That is a common question. So, other things that are important to know that could be a medication error is non-toxic therapeutic, is to ensure non-toxic. So that is where when a medicine says to make sure what are their current vital signs, most is lithium, warfarin, theophylline, and digoxin. What do you know about digoxin? In your mind, you should already have implanted if you're going to give that med. If the apical heart rate is less than 60, then I need to make sure that I verify with the healthcare provider that he wants me to go ahead. Digoxin and these other meds can become toxic. Warfarin, that can be determined on what's the patient's. If the patient forgets and eats soup and it has a lot of spinach in it, it can have a lot of vitamin K. Vitamin K is the antidote, and you can have toxic effects. So it's important to know what lab values do I have to know. If a patient's in chronic renal failure and the medicine is excreted through the kidneys, I need to know what was their most recent creatinine clearance rate. What are the lab values I have to know before I give this medicine? So this is not testable. This is Ms. Cook. Preparation for medicine administration. What is the name of the medicine? What's the purpose of the medicine? What effect will it have? Those are those known side effects. How long will it take for the medicine to work? What are the side effects, adverse and or signs of an overdosage? Are there any interreactions with the medicines? And we'll get into that in our oral medicines. One of the things I learned, I have children that take for ADHD medicine, and I did not know that the daily morning drink that I was giving them as breakfast essentials, I wanted to make sure because it makes them anorexic, I was giving them breakfast essentials every morning, and it has vitamins in it that are contraindicated to give at the same time you give the ADHD medicine. So are there any special administration or storage? Some medicines have to be stored in the refrigerator. Some of them cannot be stored in the refrigerator. And again, always remember to only give the medicine to make sure you have all the information. So Medication checklist. Who are the personnel that are authorized to give medicines in acute care facilities? Registered nurses and registered professional student nurses under the direct supervision of an RN instructor for teaching purposes. You can only give medicine under the direct supervision of an RN instructor or the staff nurse, and initially in level 1, you should always verify. So one of the things adult education says, if I have a mnemonic, so I have included this mnemonic, tramp my meds. Do I have the right time, the right route, the right amount or dose, the right medication, and the right patient? These are important steps to giving medication. So to verify that we have all of those, there's 3 times that we check. It's called the triple check system. The first, oh, go back. Where did it go? Sorry. The first time you double check, each time on the triple check, you check, do I have the right drug, the right patient, the right dose, the right route, and what is the expiration date? Those 5 things. The first time is when you remove it from where it is stored, whether it be a med room or a med cart. When you pull that med, you're going to check, and that, oh, go back, stop. I got to click it. So the first P is pull, when I pull. The second triple check, sorry guys. The second triple check is when you prep the medicine. So the medicine comes in a vial, and I'm going to draw it up in a syringe, or I'm going to take it out of the container. When I prep the medicine, I'm going to check is this the correct drug, the correct dose, the correct route, the correct patient, and the expiration date. And the third check is after you've prepared it and before you administer it to the client. And that is when you pass. Pull, prep, pass. That's your triple check. In my mind, the day that those nurses, 4 different patients, got the wrong dose, 3 times did they go in and check the drug, the dose, the expiration, the route, and the patient. If you follow the triple check system, you're much less likely to not have a medication error when you are passing meds. And that's in box 35.5. Sorry about the page numbers, Mr. Keller, okay? So part of the safety modules that they've developed are automatic medication dispensing systems. And you will be oriented to this when you get on your clinical unit. They can be separate carts. It may be a mobile cart, a drug cart that rolls from room to room, which is what you see here, or it may be built into a unit in your med room. This is very similar to the one that they have at University Medical Center, and it is fingerprint. You have to put your fingerprint in there to access the medicines. Most facilities do not allow students to have access. Your instructor or your staff nurse will have to pull the medicines. So you identify that you are the person appropriate to pulling this medicine. Then it will bring up a patient list, and I don't have it. These are all copywritten, so I don't have it here. But it will pull up your list of patients, and it will have the medicines that for the time that you're pulling them that you'll expect. It'll say either PRN. It'll look similar to the MAR, but not fully like the MAR. But it should have a list of the medication, the dosage, the route, and it will have the location of the medicine in the as it is. So it'll tell you what drawer to pull. And if you look here, I know it's fuzzy. I tried to make it as clear as I had. There are 3 different drawers, so it's important. It'll tell you, pull from bin A, B, or C, or whatever the label is for that medicine. And then after you pull the medicine, when you pull that medicine, you're going to do what? First check the drug, the dose, the route, the patient, and the expiration. That's the first check in it. Sorry. The other thing is that these have built-in safety controls. You'll see here the barcode scanner. If you have need a second nurse to sign off on a high alert med, they'll have to sign in when you're doing the second check, and they'll sign in through the system as well. And it also has narcotic controls. There are times you as the nurse will be expected to do a narcotic check. Depends on your facility policy. It can be either usually once a day or once a shift. When you are responsible for doing a narcotic count or doing any count, don't assume, don't one person, if you are signing in, look and make sure those are the numbers. There, unfortunately, there is an incidence of nurses that divert meds. Make sure if you're signing off that you actually see the meds and do the count when you're assigning them. Okay. Okay. Routes of administration. So part of this lecture and part of you knowing is what are the advantages and disadvantages of either oral meds, IV meds, inhaled meds, or injected meds. In level 1, we do not cover IV, and we do not do some inhaled meds. Those are covered in level 2. So for this lecture, we're going to start with the oral route. I'm sorry, you guys. So oral route is any medication that is swallowed. That's the definition of an oral route.
Ms. Cook?
Yes?
Sorry, I just wanted to make sure you knew it was 10:20.
Oh, okay. We will come back and we will start here next week. Thank you. Yeah, I get going and I don't pay it. It doesn't tell.
It's no problem. I just wanted to, if people had questions and then if people have to leave for farm,
Okay. No, we will end there and we will come back right to routes of administration.
Thank you, Ms. Cook.
You're welcome. Any questions?
Ms. Cook, I have a question real quick before farm. So this goes back to the home orders at bedside. If you can't leave meds at bedside, how are you able to leave a home order there? What if they take extra when you're not around?
For home medication, you're going to ask the doctor, can they self-administer?
Okay.
And it's written in the order, patient can self-administer.
Thank you.
Ms. Cook? So would you go get a new inhaler from the hospital's pharmacy, or can you use what the patient use what he brought in?
It depends on the doctor's order. Usually they can use the home bronchodilator or inhaler, whatever they're using. Excuse me.
Does that go for like blood pressure meds too, or anything else?
Usually not bread. Some of it is some of your birth control meds, some of those other specialty meds that the hospital doesn't have in its formulary, but the doctor wants them to continue while they're in hospital.
Okay, thank you.
And I know, like with my son and his autism meds, the hospital doesn't carry those, so we would have to take those with us. Okay. Any other?
So bottom line, just ask the doctor or have an order.
When you get that order, you want to have that clarification, yes. And depending on your pharmacy, whether or not you have to send it to the pharmacy to be identified and labeled by the pharmacy.